Hello, and welcome to our webinar on the role of the dentist in managing sleep-breathing disorders. Snoring has been present since the dawn of humanity. It affects the sleep quality and the life quality of millions of people around the globe who have to put up with terrible noises during their sleep. Sleep apnea has always been present forever, but interest in managing and treating this silent killer disorder has developed during the last 20 years. Dentists have a role in managing these two disorders, essentially in screening and oral appliances to reposition the mandible to open the airway. Dentists are usually not very familiar with sleep apnea and sleep breathing disorders, so we will talk briefly today about sleep apnea, and then we'll present oral appliances to treat snoring and sleep apnea. This video will show you an apneic patient, so you can realize how dangerous this disease is. The patient has just stopped breathing, and in a while we'll start looking at the thoracic and abdominal belt to see the effort that the patient does to be able to breathe. And you can also see how long it takes for the patient to breathe again. And this is the phenomenon that is repeated 50, 100, 200 times per night, every night, all year. Another breathing pause, another apnea. See the abdominal effort and thoracic effort. The patient is pushing, pushing, pushing in order to be able to breathe, to no avail first. Then he's going to open his mouth and snore loudly. So imagine again, all night, every year. So we'll talk about oral appliances for the management of snoring and sleep apnea. What are the indications? The indications are primary or heavy snoring, mild to moderate obstructive sleep apnea, certain cases of severe sleep apnea, poor tolerance for CPAP, CPAP being continuous positive airway pressure, failure of UPPP. UPPP is a surgical operation where the uvula and the palate, the extension of the palate is removed surgically. It could be used as an alternative to CPAP during travel or in combination with nasal CPAP. Mandibular appliances are used in the mouth during sleep to prevent the oropharyngeal tissues and the basis of the tongue from collapsing and obstructing the upper airway. They usually reposition and stabilize the mandible, the tongue, the hyoid bone, sometimes the soft palate. They increase the size of the airway in lateral dimension, and they increase also the baseline genioglossus muscle activity. This video will show you schematically how an oral appliance work. So, during sleep, tongue and the bases of the tongue collapse and they obstruct the entrance of the airway. So, an oral appliance is placed in the mouth and then adjusted. The more you advance, the more you bring the mandible forward, the more the tongue and the bases of the tongue are brought forward, and the more you open the entrance of the airway. So air can pass and no vibrations or no snoring. This video is a courtesy of Dr. Florence Morisson. Anatomically, we can see this In endoscopy, we can see when we have a mandibular advancement, the lumen, the opening of the pharynx is much more open than only with neck extension or just with mouth opening. So it's not the vertical dimension that's important, but it's the anterior displacement of the mandible or mandibular repositioning. These are the guidelines, the medical guidelines. It is recommended that sleep physicians prescribe oral appliances rather than no therapy for adults who request treatment of primary snoring. When an oral appliance is prescribed by a sleep physician for an adult patient with obstructive sleep apnea, we suggest that a qualified dentist use a custom titrable appliance over non-custom oral devices. We recommend that sleep physicians consider prescription of oral appliances rather than no treatment for adult patients with obstructive sleep apnea who are intolerant to CPAP or prefer alternate therapy. And we suggest that qualified dentists provide qualified oversight rather than no follow-up. We suggest that sleep physicians conduct follow-up sleep testing to improve or confirm treatment efficacy rather than conduct follow-up without sleep testing. And we suggest that sleep physicians and qualified dentists instruct adult patients treated with oral appliances to return for periodic office visits with a qualified dentist and sleep physician. When are we successful with oral appliances therapy? If the AHI is lower. AHI is the apnea-hypopnea index. When the patient has a low body mass index, when the patient is younger, when you have a high ratio of hypopnea to apnea rather than apnea to hypopnea, and if the degree of desaturation is less, if the OSA is positional, and if the arch is narrowed, and if you have a hyoid bone, if the patient has a hyoid bone. Functional classification of oral appliances. We have two sorts of oral appliances, either the tongue retaining device that we barely use or the mandibular advancement devices that we're going to show. You can have a tongue retaining device like the one pictured here. And you have multiple kinds of oral appliances. Some are non-adjustable. They could be monoblock, thermocryl, thermoplastic, or laminate, or even in acrylic. However, their use has been really discouraged during the years because they're non-adjustable. You can have devices like this, bi-maxillary devices. You can have it fixed in acrylics to titrable or adjustable appliances. The choice is tremendous. We have around 100 appliances available on the market. We're going to talk about the most used appliances, starting with a rather simple one called the EMA appliance. EMA for elastic mandibular advancement. We have two thin shells linked by an elastic on both sides. The way you advance the mandible is by changing the tension and the length of the elastic. The shorter the elastic, the more advanced you are. It's quite a simple and easy to fabricate appliance. However, it doesn't last too long, but it's an affordable alternative. The Hertz appliance is probably one of the most used appliances in orthodontics for removable appliances to treat a class 2. So these are mandibular repositioning appliances, and they can be used in sleep apnea case. The adjustable PM positioner is a very old appliance and is an affordable alternative. The TAP or Thornton adjustable positioner is named after its inventor, Dr. Thornton from the United States. It's very commonly used in the United States, has its advantages and some of side effects or inconvenience if you want.
because the advancement mechanism is outside the mouth and can bother the patient. The hook that you see here comes on a mandibular bar, and some patients complain that it bothers the tongue, but it's also a very commonly used appliance. The silencer is a Canadian appliance invented in British Columbia, Canada. It's a very sturdy appliance. It comes with a thermoplastic shell with advancement like a gearbox, if you want. So you go from one notch to another, to another, to another. And the attachments here are made of titanium, so very solid. However, the problem is that in the long run, sometimes you have what we call delamination. So the whole mechanism here will become detached from the shell, because the shell is made of thermoplastic material, and with time the thermoplastic material will deform. The Clearway is another Canadian invention. It's been invented in British Columbia by Dr. Alan Lowe, and it's a very used appliance on the west coast of Canada. However, it started becoming less and less used because, again, of the material, that is thermoplastic. When you have detachment or breakage of the metallic part on the appliance. But for example, I've used it for years and with very good results. However, because of all the metal that you see on the palate and in the mouth, it can be bothersome to some patients. The dorsal appliance is one of the most commonly used appliances now. It comes with different sizes and colors. It's a cheap alternative to the most used appliance on the market now. It's called the Sonomet. This is a very solid appliance called the Strong appliance, or the SWAT device. It's a cast frame, like a chrome cobalt frame, linked by some mechanism like you would use in the Hertz appliance, come with very solid screws and rivets, plus elastic and a thermoplastic liner. Its advantage is that it's very long lasting. The disadvantage is it's very cumbersome and very big in the mouth of the patient. This is another view of the SWAT device by Strong appliances. The Sonomet is most probably the most used appliance in the world now. It comes in different shapes and designs. The most commonly used is what you call the Flex appliance. It's an acrylic shell. The outside is hard resin acrylic. The inside is a softer, flexible liner, or softer liner. It's not thermoplastic, it's just flexible. On the maxilla, on the two sides, you have the advancement mechanism. And by turning the screw over here, you advance the mandible by 1/10 of a millimeter at a time. This is how we do it. So we put a key in the slot over here, and then gradually we can advance the anterior part that pushes the lower mandibular triangles and bring the mandible forward gradually. The advantage of the Sonomet is that, first of all, it's a very well fabricated appliance. It It's guaranteed for 3 years. It lasts for about 4 to 5 years. And it's a comfortable appliance. One of the other advantages for us dentists is that we can titrate or adjust the mandible by very small increments of 1/10 of a millimeter, like you were saying, and you can advance the right separately from the left if you have any muscle or joint problems. This is what it looks like in the mouth. You have an upper part and a lower part, of course, and the patient can open his mouth and drink a sip of water, for example, or even if he has to say a few words, he can. This appliance can be used in edentulous cases, partially edentulous, I should say, because the maxilla can be edentulous. However, the mandible has to have at least 8 teeth. In the case that we have here, we have 60. And despite the less than required number of teeth, we were able to fabricate a very stable appliance and a very successful one. So impressions are made, bite trims are made exactly like you would do for a complete upper denture and a partial lower denture. However, the bite trims for the occlusion are not made in centric relation, but they are fabricated and placed in protrusive position. So this is the result. You need, usually, like I said, you need at least 8 teeth to have a stable lower part, and amazingly, the upper part is extremely solid, and you would have to exert a lot of pressure to be able to remove it. In some cases, the Somnomed can be used on implants. In this case, we had an upper arch that was restored with ball attachments, and were able to fabricate an appliance with female attachment inside of the upper part of the orthosis. Thus, you won't put too much pressure on the attachment and on the implants. It's important to remember that instead of removing your upper denture during the night, you still wear something, plus you put pressure if you have any bruxism or you bite on your teeth during the night. So these are examples of patients. Another appliance that we've been using recently, and it's fairly new on the market, is called the ProSomnus. This is the classic ProSomnus. It is a CAD-CAM, so computer milled appliance that could be used with digital impression. So you take your digital impression, you send the STL file, they can fabricate the appliance according to your digital impression. And that's quite convenient. Most appliances now are being CAD-CAM made or starting with a digital file. It's convenient because you can send your impression halfway around the world. They can print models, and then they can fabricate an appliance and will save the models, so models won't break. And if there is any problem, you can just ask for a new appliance. So this appliance doesn't have the advancing mechanism that we find in appliances like Somnomed or others. You just change appliances. So you have one set, upper and lower appliance for a 60% advancement, let's say. Then you'll have one for 65% advancement and one for 70%. And you can order as many appliances as you want. This is the new ProSomnus, the CA, Continuous Advancement Appliance. So it has, like the SomnoMed, the same kind of advancement where you can advance by turning the knob here. You put, like we did for the SomnoMed, you put the key in the slot here and you advance towards the arrow 1/10 of a millimeter at a time. Again, it is a CAD/CAM milled device. Then they add the advancing mechanism. Is it good? Quite good. This is probably one of the best appliances and the one I use along with the SomnoMed. The advantage of this is that the advancement is curved and doesn't go on a straight line, so it will tend to break less. This is what it looks like in the mouth. Okay, this is the classic ProSomnus that I don't use a lot nowadays, and this is the CA appliance that is quite good. It's more rigid than the SomnoMed. It doesn't have the flex lining, but it's a quite good. The adaptation is quite good. And then you can have something like this. Don't ask me what kind of appliance it is. I asked what kind of appliance it was, and the patient didn't know. Someone in the United States referred a patient to me who had this kind of appliance for a follow-up, just to make sure that everything was okay, because the patient had moved back to Quebec. And I didn't know what kind of appliance it was, and he didn't know neither. So I tried to get in touch with the office of the dentist who referred him, and unfortunately I had no answer. When I looked at the appliance, I said, my God, I don't know how it works. And it was working. I have to admit, it was working. I just had to change the elastics. Make sure when you do an appliance, when you fabricate the appliance and you fit it, that you have what we call lip competency. It means that the patient is able to close his lips around the appliance, because otherwise the patient will keep his mouth open, and then you can have either mouth breathing or muscle pain or TMJ pain. Of course, next to the custom-made appliances, you can have thermoplastic appliances or ball and bite appliances. They are available on the internet for very little amount of money. You can buy them in some specialized website, and the only thing you'll have to do is put them in a water bath or in just hot water, and then you adapt them in the mouth of the patient. Some of them are more fancy, where you can have an advancement mechanism like this one here. Does it work? Probably for a few days. Beyond a few days, it won't work. So you have this, where you can put registration paste or impression material, and then make the impression of the upper arch and the lower arch, and then advance it gradually. Some come even with their own thermometer, where you have to measure the temperature of the water where you're going to put the thermoplastic or the ball and bite appliance in. Or you can just fill them like this one here with impression material or bite registration paste, and it holds more or less in the mouth, not for too long, unfortunately. So after looking at most or a lot of oral appliances, let's see what are the anatomic and physiological effects of mandibular advancement devices. In resume, an oral appliance or a mandibular repositioning appliance will increase the airway caliber in lateral dimension. It will increase the airway size at level of the velopharynx, and it will increase the genoglossus activity like we just said. This is a cephalometric X-ray of a patient without an appliance and with an appliance. In this case, it was the clear way where you can see all the metal of the appliance. What is important is the airway space, the airway volume that increases when you reposition the whole body of the mandible forward, because you also reposition the tongue and the basis of the tongue. This is an MRI, a 3D reconstitution with MRIs of the volume of the pharynx before inserting the oral appliance and after. And this is another view, a lingual view of the increase of the volume of the pharynx. These slides are courtesy of Dr. Alan Lowe from British Columbia. This again, you can see when you position the tongue forward, this is the space occupied by the tongue and the basis of the tongue, the pharynx or the airway in the back is increased in volume in 3D, and that's extremely important. So we have reviewed so far a few examples of oral appliances and see the mechanism of action of the mandibular repositioning appliance in the case of snoring and sleep apnea. Let's go now to bite registration and impression. Then we will see the fitting of the oral appliance. The protrusive bite registration should be between 60 and 70% of the maximum protrusion to start with. Some have advised to start at 50%. However, usually 50% for most cases is not enough. So we start usually at 60%. So we need to measure first the protrusive range of movement. It does depend on the patient's range of movement, of course, like we just said, and if there are any temporomandibular disorders or any muscular implications. The bite registration should be taken with a stable material, usually PVS. You have to ensure that the skeletal midlines are aligned, and in order to register the protrusive position, we recommend using a George gauge or a similar kind of gauge. Again, the clinical predictors for successful treatment with a mandibular repositioning appliance, the clinical predictors are a younger age. So the younger the patient is, the easier it is to protrude the mandible, usually not in every case, but most of the time. And we tend to be more successful in younger patients. And again, if we have a lower body mass index, if we have supine dependent obstructive sleep apnea, if we have a smaller oropharynx, a smaller overjet, a shorter soft palate, a smaller neck circumference, and a lower apnea-hypopnea index. If we use the cephalometric predictors, we can see the soft palate on the cephalometric X-ray. We can see the longer maxilla, and if the distance between the mandibular plane and the hyoid bone is decreased. This is the easiest instrument to register the bite in protrusion. It is called a George gauge. We have two components, a bite fork that we're going to use on the maxilla, and the lower sliding ruler, or the body if you want, that we're going to use on the mandible. The incisor clamp is used on the two lower central incisors on the midline essentially. There's a notch here that you can align with the lower midline. So you have bite forks with 2 or 4 incisor thickness. This is the incisor thickness here. So for some appliances, they're going to ask you to use a 2 millimeters one or a 5 millimeter one, depending on the appliance you use. To give an example, the Somnomet Flex, the lab will ask you to use a 5 millimeter to have enough thickness of acrylic and enough thickness of the flex material in order for the appliance not to break, especially if you have bruxes. So this is it. The white fork that you see at the bottom here is the 5 millimeter anterior thickness, and the gray fork is the 2 millimeters. You can have also short arch forks and the large arch fork, depending on the size of the arch, of course. So with the upper and lower incisors in their respective notches, you measure the patient in centric position and you know the position on the millimeter rule. Then you ask the patient to go to maximum protrusion and you know this position. So now you have a range, and normally the protrusive range, the maximum protrusion, the average maximum protrusion is 10 millimeters between centric position and maximum protrusion. So you're going to take the 60 to 70% of that maximum range. This is an example where we have 5 here, but like I said, we have 10. You use the 2 millimeter fork for smaller appliances. If the curve of speed is excessive, you're going to need to compensate for this in order to have enough thickness. Then you're going to use the 5 millimeter fork. If the incisal edge of the central incisor does not touch the bottom of the groove because of crowding, you can adjust the palatal portion of the incisor guide rather than the labial portion of that incisal guide to have a better adaptation of the maxillary fork. You line up the facial midlines and you note any deviations, because you have to understand that first of all, naturally you can have midlines that upper and lower midlines that are not aligned, and you could also have midlines that are not aligned in normal protrusion. So you're going to verify, you're going to check that the protrusive movement is done in a straight line, and it's not always the case. So you have to note this and inform the lab about it. You have, of course, to measure the start and finish position, and you need an adequate range of movement. 6 millimeters is the minimal in most patients. Like I said, we have usually on average 10 millimeters protrusion. So let's say the centric position is -5 and the protruded position is +5. So we have now a 10 millimeter range of protrusion. The jaw position can be set at 2/3 or 60%. 2/3 of 10 millimeters is 6.6, and you can measure it. It's very easy. You repeat it just to make sure it's consistent and reproducible. For most patients, 2/3 of centric to maximum protrusion is a valid formula. Depending on the case, you could have, like we said, you could have muscle pain or muscle problem, joint problem, TMD. So it may be necessary to advance the mandible by gradually titrating, by gradually adjusting it forward. Once the position is obtained, you ask the patient to hold in that position for 2 to 3 minutes and see the feedback. It means if you advance the mandible, let's say 6 millimeters, just to give an example, you ask the patient to hold that position. If after 2 to 3 minutes the patient is complaining of muscle soreness or fatigue or pain, it's better to start at the lower or a more reduced protrusion, let's say in this case, let's say 5 millimeters. So the gauge with impression material is returned to the mouth with lower incisor notch center over the midline. Then you unscrew the fork and you send your model with the fork. Of course, now we can use, like we said, digital impression. We're going to talk about it in a few slides. Impressions. Traditionally, impressions are made with alginate. It's a cheap, fast, convenient impression material and can be pretty good. Is it extremely precise? No. But it's a good alternative. Of course, the best would be PVS. We can use nowadays digital impression, and it's more and more common to use digital impression to send a digital file that can be very convenient in case the model breaks while being transported. You can have the lab pour another model easily, starting with the file that they keep in archive. It is important to have an informed consent for the mandibular advancement splint. A little bit later in the presentation, we're going to talk about possible side effects. So it's important that the patient understand what he's getting into, that this is a therapy for a medical problem that could have side effects like pain, like teeth movement, like jaw movement. So you have to explain this and have the patient sign this informed consent. Two to 3 weeks later, you will receive the oral appliances and you're going to fit it. It's very easy to fit. You would fit it like you would fit a partial denture or an occlusal splint. It's very easy. Usually the patient might have a complaint in the beginning about the length of the mandibular stops, like here, and you can reduce them with an acrylic burr. Make sure before you start the advancement that the maxillary portion and the mandibular portion fit very well on the teeth. It means the appliance should be, the fit should be snug. However, you shouldn't have too much pressure on the teeth and certainly no pain. If the patient complains of pain, it is usually due to either the flex material or the acrylic, depending on the material used on your appliance, being too tight interproximally here. So you can remove the interproximal material that can impinge either on the papilla or press too much on the teeth. You will adjust it like you would adjust an occlusal splint again, or like you would adjust a partial denture. You have to check your occlusion. What does it mean? Of course, in a case of an oral appliance, you don't have teeth touching. You have two acrylic surfaces touching each other. However, you have to make sure that bilaterally, right and left, you have the same intensity of contact. And you do it with a simple articulating paper. You will not have occlusal contact, you will have just positive contact. and they have to be even on both sides. Even bilateral pressure is very important, not to create muscle pain, not to create muscle imbalance or joint pain in the future. After fitting the appliance, make sure it fits evenly, snugly, but with no discomfort or pain. You give instructions to the patient, and these are the instructions for a somnolent. You place the top part first, then the bottom, then you remove the bottom and the top. You get used to the appliance progressively for 2 to 3 days. You wear it in the beginning for half an hour, then you take it off for 5 minutes. You give yourself a little break. Then you wear it for an hour. You take it off again for 5 minutes, and so on. It takes usually 2 to 3 days to get used to it. And I tell my patient, don't hurry. Take your time to adapt to the appliance in order to be able to wear it for the long run. If you start immediately, then you have pain on your teeth or your muscles or your joint, the patient is going to be discouraged to use the appliance. So I'd rather wait 1 more night, 2 more nights, 3 more nights, just to make sure it fits okay with no pain, and then wear it gradually. Usually after 2 to 3 days, there should be no problem wearing it for the whole night. In the morning, the patient has to do the jaw exercises, and we're going to see right after what kind of exercise he has to do. So the patient does the jaw exercises as soon as he removes the appliance. This step is primordial. It is very, very, very important to do the repositioning exercises. Why? Because the jaw has been forward for 6, 7, or 8 hours, depending on how long the patient sleeps. So the jaw has to go back to its normal position. Otherwise, you can create jaw pain, muscle stiffness, joint pain, and in the long run, this will promote not occlusal changes, but bite changes, because you will have the mandible reposition itself gradually forward. This is something we want to avoid as much as possible. It is normal to feel jaw stiffness or pain in the morning, or to feel a slight change in your bite. The patient has to be advised. This is normal. For about 15 to 20 minutes, the patient will feel that his teeth will not fit positively. After doing the exercises and after chewing for breakfast, let's say, it should go back to normal. It is also normal to feel that the teeth are sensitive, usually for about 15 to 20 minutes, not more than this. Please advise your patient that if the bite does not come back to normal, or if strong pain occurs, to stop wearing the appliance and call you ASAP as soon as possible. Do not let pain become chronic. It can be fixed very easily by either reducing the wear of the appliance or retruding a little bit the appliance in order for the muscles to adapt to a new position. How do we clean and how do we care for the appliance? Normally the appliance should be rinsed with cold or lukewarm water and brushed with a soft toothbrush. Use, please, antibacterial soap. No color additive to the soap. Antibacterial hand soap is very good to clean an appliance with a soft toothbrush. You rinse the appliance very thoroughly. Do not use toothpaste. Toothpaste contains abrasives. the abrasive will damage the appliance and the components of the appliance. Usually the appliance, unless asked, depending on the kind of appliance you use, of course, unless instructed by the manufacturer, usually the appliance should be kept in water in a container to prevent cracking and corrosion if you have especially acrylic. Now, twice weekly or 2 or 3 times a week, you soak the appliance in water and you add an effervescent tablet for up to 15 minutes. For example, you can use Polident. In case of Somnomed or ProSomnus CA, it is important to use Polident for partial. Any appliance containing metal should not be disinfected with an effervescent tablet like a regular one, like acrylic, because you could have, the metal could corrode. You brush and you rinse thoroughly, and then you submerge in water. Of course, you change the water daily. You clean the inside and the lid of the container daily to prevent bacteria growing inside the container. And then your appliance becomes a Petri box, something we want to avoid, of course. It is normal to have a light plastic taste for the first few days because the appliance is new, but this taste will disappear after it is soaked in water for a period of 2 to 3 days. These are the exercises we do every morning. With 1 or 2 fingers on your chin, you're going to apply pressure retrusively, meaning you're going to push back the mandible to its normal position. You push back gently in order to avoid pressure in the capsule of the temporomandibular joint. If the patient, while pushing, feels pain, it means he's pushing too much. So the patient pushes back and then he stretches his mouth open. Very gently, you push back and then you stretch open and close, open and close for about 15 times. And this is recommended for any kind of repositioning appliance to avoid muscle pain, joint pain, and jaw movements. We have a lot of studies that prove that mandibular exercises improve mandibular advancement device therapy for obstructive sleep apnea. Why? Because you prevent having muscle pain. By preventing having muscle pain and or joint pain, you increase the efficacy and the usage of the oral appliance, so a patient will be more satisfied and will use it for the long run. And of course, you can have some special exercises that will improve and increase the muscle tone of the larynx and pharynx muscle. We can use also what we call an occlusal wafer. These are wafer, this thermoplastic material, you put it in boiling water, you adapt it to the maxilla or the mandible of the teeth, and then you record the CR position of the patient before you start the therapy. So every morning the patient will remove his oral appliance, do the stretching exercise, and go use the wafer, could be either on the maxilla or the mandible, where you have the indentation of the antagonist teeth, and then the patient would try to retrude his mandible to make his teeth fit into the indentation, and then you squeeze gently a few times for about 30 seconds, and then you can find your occlusion, your normal occlusion. Some use what they call the morning positioner. I prefer personally. It's a good device. However, I prefer the wafer personally. This is the kind of mandibular device called the morning positioner, and the patient will bite a few times and chew on these occlusal subs, so it can act as a retruding jig to find back his original position. Some devices will help your patient sleep better, and you have little devices like this one here called this little sleep machine. The patient will use the headsets and hear soothing and calming sound that will promote better sleep. And of course, nowadays we all have what we call intelligent phones, and you can download from the internet dozens of applications that are able to record not your apnea, but can record the sound that you make during your sleep. And some applications are pretty good and can discriminate the noise, all the noises that you make during your sleep, and know if these noises are snoring, and they will give you the intensity, the time, the amount of time you snore during the night. So these are pretty good. It's an indicator. It is not a sleep test. It is an indicator to know if you have persistent snoring for your patient. If you still have snoring, of course, you're going to advance and titrate your mandibular positioning appliance. Some other useful tools are like what we have here. It is called the wedge pillow. So patients will sleep with the head on this pillow, with the head lifted up a little bit, so they can open the airway a little bit better instead of being on a supine position with the head tilted back and the tongue falling more in their throat and having more snoring and more apnea. Of the fit of the appliance, an occlusal evaluation, making sure you don't have occlusal changes, that your contacts have not changed. You're going to palpate the muscles, you're going to palpate the masseter, you're going to palpate temporalis, you're going to palpate the digastric, you're going to palpate the lateral and internal pterygoid, the neck muscles too. Make sure you have no pain, and then you schedule your follow-up appointment. You titrate your appliance every time you see the patient, up to the time where you have no more snoring or no more signs and symptoms. And it's very easy. Like we said, you put the metal key in the slot here and you advance 1, 2, 3, 4, or 5 tenths of a millimeter depending on the case. If the patient complains that his teeth that the appliance is too tight on the teeth, you will adjust the inner side of the appliance, essentially the interproximal acrylic or flex material that you see here. So every time you check the occlusion, you verify the contact on the appliance, you palpate the muscles, you palpate the joints, you verify teeth mobility, and you review the exercises. Very, very important. This is your checklist. At every appointment, you're going to do exactly the same. Once you're used to it, you're going to do it very easily. Check the occlusion, check your occlusal contact. At one point, when the signs and symptoms of the patient have disappeared, the patient will tell you, I snore no more, I feel asleep much better, I feel more energized in the morning, I don't have a headache, I don't have pain in my jaw, I feel less sleepy during the day. You're going to have to return your patient to the pulmonologist or to the physician who has referred you the patient to run what we call a titration follow-up study. The the physician is usually going to run either a simple sleep test with an ambulatory device, what we call a class 3 device. It can be done at home. We call it the home sleep test, or HST, or it can be done in the lab with a PSG, a complete polysomnography test.
I hope you all enjoyed this presentation. I look forward to seeing you in future webinars.